conditions in which there are no placebo responses at all. There are some placebo responses which are really huge, really large in some medical conditions. For example, you see here that infections, these are bacteria. You know bacteria much better than me, of course, but it is quite unlikely that a placebo, which means fresh water or a sugar pill, can kill bacteria, of course. So I would say that there are no placebo responses in these conditions. Another example is general anesthesia. If you give a fake anesthetic gas, for example, or a pill, a fake pill, you cannot anesthetize the patient, of course. So there are no placebo responses in these conditions. On the opposite side of this straight line, there are different medical conditions. And actually we work on these medical conditions. For example, depression, for example, pain, motor performance, motor disorders in general. So my talk will be particularly about pain, about some neuropsychiatric disorders, some neurological, particularly neurological disorders, about Parkinson's disease, for example. I hope that the knowledge of this neurobiological mechanism can stimulate in the field of infections as well some new research on placebo mechanism. So this overview of my talk, I have more or less 45-50 minutes, and you see here that my talk is subdivided into different parts. The first is the very definition of a placebo, and you see that I will start from the definition of drug. Actually, it's not very difficult to define a drug. It's quite easy to define a drug. It's much more difficult to define a placebo response. Then the second part will be about what is emerging today. The concept which is emerging today is that placebos on the one hand and drugs on the other use the very same biochemical pathways. I will show you some examples. The opioid system, the endocannabinoid system, the cyclooxygenase pathway, the dopamine receptors, dopaminergic pathway in Parkinson's disease, and probably you are much more interested in this part, the endocrine and particularly the immune system. We know very, very little about the mechanism here in the immune system, placebo response in the immune system, the endocrine system, but I just want to give you an example, a very quick example. I would say that most of our knowledge about the biological mechanism comes from the field of pain and Parkinson's disease. So then, of course, there are some similarities between drugs and placebo, but there are many differences as well. And the nocebo response, which is the opposite of a placebo. We give a placebo, but we induce negative expectations. So with the nocebo response, we study the worsening, not the improvement of a clinical condition. Then why some people respond, some others do not. This is a challenge for future research. And the emerging model, some clinical implications. There are many clinical implications. But today I would like to draw your attention on a single medical implication, particularly in this context, because I feel it's quite important. So let's start with the very definition of drug, definition of placebo. Probably I can use this one as well. Yes. The very definition of drug, if you ask this question, what is a drug? It's not very difficult to define a drug, because usually a definition of a drug is that drug is a molecule which is introduced in the body, and this drug can modulate different biochemical pathways. For example, if you inject a molecule, you can modulate the opioid receptors if you use a narcotic drug, or you can modulate COX, the cyclooxygenase, if you use a non-steroid anti-inflammatory drug like aspirin, for example, So this is the very definition, very simple definition of drug. A molecule which is introduced in the body can modulate different biochemical pathways. So if we change the question and we ask what is a placebo, the answer is much more difficult. Usually I would say that the most common definition of a placebo is that a placebo is a fake drug. It's true, it's a fake drug, but the definition is not complete because something very important is missing. And actually, if you want to answer, if we want to give a complete definition of a placebo, is that a placebo is a fake drug and the psychosocial context around the therapy, around the treatment. You see here, but I mean, around the treatment, around any patient, there is a very complex, very complicated context, like you see here, for example, the site of hospital, the health professionals, you know, the smell of drug is important as well, to be touched by complex machines is important, or by the needle of a syringe, you know, could be a very important sensory stimulus. And of course, needless to say, the words by health professionals are very, very important. So all these sensory stimuli are also social stimuli, which tell the patients now there will be an improvement in your clinical condition. That's the psychological, psychosocial component, which is very, very important. In a single word, or better, in a single sentence, we can call all these sensory stimuli and all these social stimuli, you see here, the ritual of the therapeutic act. You know, there are many rituals. You don't need to see here all the rituals, but just for the sake of clarity, you see here that, for example, these are very common rituals in the clinical setting. The ritual of taking a pill, the ritual of a shot, the ritual of surgery. Surgery has a very powerful psychological effect on patients. The ritual of CAM therapy, so like, you know, like acupuncture. The ritual of acupuncture is very complex. So it tells the patients now you will be better because I'm going to perform a therapy which is pretty powerful to reduce your pain. Or the ritual of psychotherapy is important as well, or the ritual of medical device, or shamanic rituals. Sometimes shamanic rituals are not different from the rituals of conventional or mainstream medicine, you know. So I'd like to go back to return to the definition of drug. The modulation, a drug, a molecule modulates the different biochemical pathways in the patient's brain. Well, what is emerging today is that all these rituals and all these sensory stimuli modulate the very same biochemical pathways, which are modulated by drugs we give in routine medical practice. For example, if you give morphine, morphine is a powerful painkiller, it's a narcotic drug. If you give morphine, morphine binds to these mu-opioid receptors. But expectations about receiving morphine, but actually you receive fresh water, it's just a placebo, just the ritual of the morphine injection. So expectation about receiving morphine, but actually you receive fresh water, activate the very same opioid receptors. And this holds true for the other receptors as well, for other biochemical pathways. I will show you three or four examples. So this is another important point, because usually people ask me what is the mechanism of the placebo response. Actually, this is the wrong question. The correct question would be, what are the mechanisms, the plural? What are the mechanisms of placebo response across different medical conditions, across different therapeutic interventions? You see here that there are many mechanisms, and we know pretty much about pain. I would say that most of our knowledge about the neurobiology of the placebo response comes from the field of pain and analgesia. We know something about Parkinson's disease. We know much less about these neuropsychiatric disorders, and alas, we know very, very little about the immune system, the endocrine system. So probably within this context of infectious disease, we are much more interested in this part, but unfortunately we know very, very little. So I will show you in a while, I will show you a couple of examples in these two systems, the immune and the endocrine system. So let me start with pain, just to show you what is going on in the brain of the patients when you give a placebo. So to give a placebo means to give positive verbal suggestions, to induce positive expectations. That's a psychological effect, basically a psychological effect. So it's not surprising that a psychological effect is important where in the medical condition where the psychological component is important, like pain, like motor performance, motor disorders, Parkinson's disease. is less important, of course, when we talk about infectious disease, the psychological component, I mean. So let's start with pain. I would like to start by showing you a very good placebo responder. Unfortunately, not all patients respond like this one. We don't know why exactly. I will return at the end of my talk on this point, which is quite important, and I would say is a challenge for placebo research. And these patients underwent thoracic surgery for lung cancer, and you see here, this is a surgical wound which is pretty painful. So if you ask these patients to perform the full range of movement in this way, you see that there is a limitation of the range of movement. There is a limitation of the range of movement because the surgical wound is painful. This is not surprising at all, of course. But if we give a placebo, which means we give positive verbal suggestions to induce positive expectations, to stimulate the psychological component, and we ask these patients, after we give a placebo, to perform the same movement and to try to reach the extreme position. In this way, you see what happens. After placebo administration, you see that now she can perform the full range of movement. This is a typical placebo response. As I told you before, it does not occur in all patients. Okay, some patients are very good responders. Some other patients do not respond at all. So for a neuroscientist like me, the question is, the crucial question is, what is going on in the brain of these patients? Why is there any analgesic effect? We did not inject any drug, actually. We only injected words, you know? So how is it possible that words, verbal suggestion, can induce an improvement, a clinical improvement? So, as I said before, there are many similarities, and I would like to start with 2 or 3 examples, very quickly, but just 2 or 3 examples. The opioid system, for example, and the endocannabinoid system. For example, we know today, for the opioid system, that narcotics bind to the mu-opioid receptors, but today we know that placebos, which means positive verbal suggestions, can activate the same mu-opioid receptors. And endocannabinoids, the story is not different. You see here that some agonists like tetrahydrocannabinol bind to the CB1 cannabinol receptors, but today we know that the placebos can activate the same CB1 cannabinol receptors. Just let me show you an example. This is a 3D reconstruction of the brain of a patient like the previous one. Okay, this is an average across different patients. And you will see an animation here, what happens in the brain of a patient receiving a placebo, which means receiving positive verbal suggestions. Okay? You will see that there is an activation in orange, an activation of different regions in the brain, and in blue you will see that there will be a deactivation, an inhibition of different brain regions. So we give a placebo, and you see here that there is an activation of different regions here. It's not necessary, I mean, to call these and to know the names of these regions. Just you see that at the cortical level and the subcortical level, which means deep into the brain, now everything is inhibited, everything is deactivated. So these regions have to do with pain processing. So if there is a deactivation of all these regions, there is also a lower perception of pain intensity. So from a pharmacological point of view, this system is quite interesting. This is an inhibitory system which can use two different neurotransmitters. You see here, and which neurotransmitter is used very much depends on previous exposure to different drugs. So this is what we call a previous experience or pharmacological preconditioning. If the patient was exposed to a mu-opioid receptor agonist, when you give a placebo is a sort of switch which turns on a memory mechanism for the activation of the very same mu-opioid receptors. But if there was a previous exposure to CB1 cannabinoid receptors agonist, when you give a placebo is a sort of switch which turns on a memory mechanism for the CB1 cannabinoid receptor. So there is a sort of memory for drug action. There is the drug leaves an imprint in the brain. We don't know where exactly and how, but it can be, this imprint can be, which means the mechanism of action of drug can be simulated by placebo administration, which is the ritual of administration of not the drug, but the fake drug. So, second example is about the cyclooxygenase pathway. You know, here the story is not different again. It's always the same. Non-steroidal anti-inflammatory drugs inhibit cyclooxygenase, but today we know that a placebo inhibits the very same cyclooxygenase pathway. Again, an example, very quickly. This is the cyclooxygenase pathway, and you see that, for example, the products of cyclooxygenase are prostaglandins like PGE2, PGF2, and so forth. So we studied this condition. We studied the cyclooxygenase pathway during a headache attack. And headache attack, there are some types of headache, you know, that are due to an activation of the cyclooxygenase pathway. You see here, for example, the activation of PGE2 induces vasodilation in the brain, and vasodilation is responsible for the headache attack. This is what happens during a headache attack. You see there is an increase in PGE2, but most important, there is an increase in PGE2, PGF2, PGI2, and so forth. You know, this is a typical response of the cyclooxygenase pathway during a headache attack. Now, if you give aspirin, aspirin, of course, is quite effective. Aspirin, the active principle of aspirin, you know, is acetylsalicylic acid. It inhibits the cyclooxygenase pathway. You see here, if you give aspirin, there is a reduction of cyclooxygenase activity, and at the same time, there is, from a clinical point of view, there is a reduction of the headache attack. But if you give a placebo, you see a placebo, the effect of placebo is much smaller. You see that the inhibition is much smaller compared with aspirin, but it can produce the very same effect, an inhibition of cyclooxygenase activity, which means a reduction in PGE2, PGF2, and so forth. And from a clinical point of view, a reduction of the headache attack. So the effect of a placebo is much smaller, but the mechanism of action is pretty much the same. It's not different. You can use the very same biochemical pathway. The third example is about dopamine receptors, and I picked this example, motor disorders, Parkinson's disease, just to show you that pain is not a special case. Different medical conditions like motor disorders, for example, like Parkinson's disease, can induce the very same effect. For example, we know that as Parkinson dopaminergic drugs bind to dopamine receptors, but today we know, you see here, that placebos activate the same dopamine receptors. So again, just let me show you, you can skip this slide. Just let me show you a PET study. We use PET with quite a complicated technique we call raclopride technique. We can perform in vivo receptor binding to see what happens in the brain, you know, when you perform or the patients perform a task. This is a Parkinson patient, and you see what happens here just before placebo administration or right after placebo administration. You see that the red spot represents the binding of raclopride. Here, after placebo administration, there is a decrease, a reduction in raclopride binding, which means, this is a quite powerful technique, which means that there is a release of endogenous dopamine. So this means that after placebo administration, there is an increase in the brain of the neurotransmitter dopamine. Probably you are much more interested to see, to make a comparison. You see here that, for example, there is an increase which is a 200%, which is really a huge increase. there is an increase by 200% in extracellular dopamine in the brain, which corresponds to a full dose of amphetamine, which means that a full dose of amphetamine and positive verbal suggestion have pretty much the same effect. They are not different. If you increase the pharmacological dose, the pharmacological effect is much larger than the psychological effect. But for a single dose of amphetamine, there is no release of no difference between the release of dopamine after placebo administration and amphetamine administration. This changes activity, changes different activities of neurons in the brain. Here, for example, you see here we record from single neurons during implantation of electrodes for deep brain stimulation, which is quite an effective therapy, quite an effective treatment for Parkinson's disease. And just let me show you what happens for a single neuron just before placebo. This is the activity of a single neuron just before placebo administration or right after placebo administration. You see that there is a dramatic change in the activity of these neurons. So if you give an anti-Parkinson agent, actually there would be no difference between a placebo administration and a real anti-Parkinson agent administration, which means that, again, the mechanism of action is pretty much the same. So the immunoendocrine system, unfortunately we know very little. I described something. I'm going to show you a couple of examples because the context here is infectious disease, but unfortunately, as you will see, we know very, very little. We don't know what is going on in the brain and what is going on in the immune system, the endocrine system when you have a placebo, when you give a placebo. So the main mechanism in this condition, in the immune system and endocrine system, is Pavlovian conditioning, which means our behavioral conditioning, our classical conditioning. You can call classical, Pavlovian, or behavioral conditioning, which means that if you associate a stimulus with a physiological response, the stimulus first is neutral, does not produce any response. After repeated associations, can induce an effect. Just let me show you a couple of examples for the endocrine system. I can skip this one. For the endocrine system, just to show you how it works for two hormones like GH, growth hormone, and cortisol. If you give a placebo for the first time, I mean, you only use a verbal suggestion. You tell a subject, now I'm going to give you a powerful drug, increasing your GH and increasing or decreasing your cortisol. And you see what happens. Actually, nothing happens. There is no change. It's not surprising, of course. You see that the psychological effect, verbal suggestion, cannot really change GH and cortisol. But you can perform a behavioral, what we call a behavioral condition, or pharmacological condition. And you will see that this holds true for the immune system as well. For example, you can use sumatriptan. Sumatriptan is an agonist of the serotonin 1B, 1G receptors. You give a sumatriptan for the first day, on the first day, and you see that this is a typical response to sumatriptan. And this is again a typical response to sumatriptan, an increase in GH, a biphasic response, first an increase and then a decrease in cortisol. Then you give sumatriptan on the second day, and again there is an increase in GH and the biphasic response in cortisol. But on the third day you replace sumatriptan with a placebo, which means with saline solution or distilled water, you know. And you see what happens. There is now a small, but there is a significant response. This is a typical placebo response. This is a behavioral conditioning, preconditioning with drug, you know, like vaccines, you know, more or less. You give many times in a row, you know, and then you replace with a neutral stimulus. The neutral stimulus is the placebo. Well, expectation, the psychological component here is not important. You see, for example, if you tell the patient, there will be a decrease in GH, there is an increase anyway. if you tell the patient there will be an increase in cortisol, there is a decrease anyway. So behavioral conditioning, the unconscious component is more important than what you expect, the psychological component. So this is a typical mechanism in the endocrine system. This is true in the immune system as well. And in the immune system, for example, in this case, the association is between strawberry milk and immunosuppressor like cyclosporine A. After repeated association between strawberry milk and cyclosporine A, then you replace cyclosporine A with a placebo and you give strawberry milk, and you can see that strawberry milk can produce the very same responses as cyclosporine A. You see here, for example, this interleukin-2, and you see that this is the effect of cyclosporine, and this is the effect of a conditional response after this pharmacological precondition. You see that it is almost as large as the response to cyclosporine. Look at this interferon gamma. Gamma interferon, you see that the response after placebo administration, after precondition, is pretty much the same. It's not different from the effect of cyclosporine. It is a sort of a Pavlovian conditioning, so if you go on giving a placebo, there is an extinction. You need the reinforcement. You give cyclosporine again, you can see that from a clinical point of view, this is quite important because you can reduce the intake of drugs in the long run. Drug, placebo, placebo, drug, placebo, by exploiting these conditioning mechanisms. So these are in the immune system. These are the immune mediators which have been found to be modulated by behavioral conditioning. For example, the association between a flavor, a taste or odor and an immunosuppressant drug, and this is the association between an immunostimulating drug and an auditory stimulus, a visual stimulus, a tasting stimulus, a touch stimulus. All these mediators have been found to be modulated and to respond to a procedure like behavioral conditioning. There is a study, I would pick this with I would be very careful. You see, for example, there is just a single study. I mentioned this study because you are expert of infectious disease vaccination, but for example, in this study in 2008, a vaccination-like procedure with placebo, with saline solution, produced the very same modulation of these immune mediators. We don't know the mechanism, we don't know anything, we know nothing. I mean, probably it could be the mechanical stimulation of the needle, nobody knows what is the underlying mechanism, you know. So, of course, there are many differences between drugs and placebos. Just let me show you just a single example for Parkinson, but it's pretty much the same. It's not different from other medical conditions, for other therapeutic interventions, for other pharmacological agents. I would like to show you the difference between a real drug here and a placebo. You see here there are 11 patients. This is quite a complex analysis, but anyway, you will see the response of single patients, 11 patients, to an anti-Parkinson agent, and here the response of 12 patients to a placebo. So you can appreciate the difference between a placebo administration and a real drug administration. You see here, for example, in this case, this is Parkinson's disease. We measure the rigidity at the wrist. Rigidity, muscle rigidity is one of the most important symptoms in Parkinson's disease. And you see, for example, for a single patient, after administration of 2 milligrams of apomorphine, this is the decrease in muscle rigidity. This is a typical response. This is a typical response to an anti-Parkinson agent. You see that it lasts more or less 1.5 hours, then there is a relapse of muscle rigidity. Now, this is true for all patients. You see that all patients respond with probably 2 exceptions. There are 2 small responses. These 2 patients respond very poorly. You see here there is a small reduction in muscle rigidity. But now look at what happens when you give a placebo. When you give a placebo, these are the response of 12 patients. you can appreciate that there are at least two differences. There are many differences, but I would like to draw your attention on at least these two differences. The first difference is the duration. Duration here of a real drug is much longer compared to placebo administration. You see here, this duration is about half an hour, a bit more than half an hour. In this case, is about 1 hour and a half. And the second difference is the variability. Here, 50%, which means 6 patients, do not respond at all to placebo administration, and 6 patients respond. So these are the two main differences. The first difference is duration in action. We don't know why there is difference. Unfortunately, we don't know exactly what is the underlying mechanism. And the second difference is that there is a huge variability. I would say that most of patients respond, Parkinson patient, I'm talking about Parkinson patient. Most of patients respond to this dose of apomorphine, and only half, 50% of patients respond to placebo administration. Sometimes even less than 50%. So what about nocebo? A nocebo response. A nocebo response, we know very little about the nocebo response for ethical reasons. There are many ethical limitations because you have to increase patients' negative expectations. So it's a sort of stressor. So it is quite unethical. It's difficult to get approval from ethics committee to perform nocebo research. It's not surprising, of course. But let me show you what happens for a nocebo response to this patient. This patient is the same patients you saw before, placebo administration. When you give a nocebo means that you give a placebo, you give a glass of fresh water along with negative verbal suggestion. So you induce negative expectations. You tell these patients, now your pain is going to increase because actually I'm going to give you a powerful hyperalgesic drug. But actually you give fresh water. Okay, you give a placebo. Now you ask these patients to repeat exactly the same movement under the effect of negative expectations, and you see that there is a further limitation of the range of movement. Okay, because the surgical wound is more painful, of course. This is what we call nocebo hyperalgesia or nocebo hyperalgesic response. So what's going on in the brain of these patients? Again, for a neuroscientist, the main question is what is going on in the patient's brain? Why is there any hyperalgesic effect? This is what happens. This again is a 3D reconstruction of the same patients. And you see that different regions are activated, and you will see that it's not very difficult to explain a nocebo response, because when you give negative verbal suggestions, you induce negative expectations, and negative expectations activate the prefrontal lobes, which are very important in anticipatory anxiety. And anticipatory anxiety activate a neuromodulator, which is CCK, which is cholecystokinin, and CCK has a facilitatory effect on pain. So you see that the explanation, the mechanism of the nocebo response is not difficult at all. You induce negative expectations. You tell the patients your pain is going to increase in the next few minutes, and you activate the prefrontal lobes, which are pretty much involved in anticipatory anxiety, and anticipatory anxiety activates CCK, and CCK has an anti-opioid action. And the anti-opioid action means that CCK has a facilitatory effect on pain transmission, and so the subjects will experience more pain intensity. So again, just let me show you a couple of studies. We have to be very careful. I consider these two studies because they have to do with vaccination. But it is quite interesting. Probably this is a stimulating point, a starting point to study, if you like, if you want, if you have time, particularly, to study nocebo effect in vaccination, for example. Just let me take these two examples. The first example is a report from French vaccine manufacturer, Sanofi Pasteur, in 2011, and you see that they analyzed 33,000, a lot of people actually, and they found that there was a measles-like rash after a fake vaccine containing only protein, sugars, or killed organisms. And here's the second example. We don't know anything. We don't know what is going on. We don't know the mechanism, of course. And this is the second example. The second example is how you perform a vaccination. This is an example of influenza immunization, you see here. In influenza immunization, it very much depends if you approach the patients with positive information or negative information. What are the positive information? The positive information is you tell the patients what proportion of person tolerate the procedure well, which means you tell the patients that the great majority of patients tolerate this treatment very well. But on the opposite side, you can perform the very same vaccination, influenza vaccination, and you use negative information. And the negative information is that you tell the patients what proportion experience adverse events, which means you tell the patients 10% of patients report adverse events. So this is a positive approach, this is a negative approach. Okay, in this study, which was published in 1996, they found, I don't know, they need confirmation, of course. I just talk about this point because we are within this context of vaccination infectious disease, you know. So less adverse events in this condition and more adverse events. I think it would be very interesting to see what is going on actually. Is there a real biological mechanism? First of all, we need a confirmation of these two studies, but it would be very interesting to see what is going on, what is the biological underpinnings of these observation. Why some people respond, some others not? This is a crucial challenge for placebo research. Actually, the most honest answer is we don't know why some people respond, some other people do not. We know that there are at least three hypotheses, three mechanisms. I would like to touch this mechanism very, very quickly. The first mechanism you see here is learning. We discussed learning in this situation for the immune system. After repeated administration of a drug like an immunosuppressor like cyclosporin A, you can perform a preconditioning. Then if you replace the immunosuppressor, or if you replace a drug, a real drug with a placebo, you can bet that virtually all patients will respond. For example, if you give a placebo for the first time to a patient in pain, some people respond, some other people do not. But if you give a placebo after a preconditioning with morphine, for example, you give a painkiller, you give morphine on Monday, you give morphine on Tuesday, on Wednesday, on Thursday, on Friday, and then on Saturday you replace morphine with a placebo, you can bet that virtually, which means 90–95% of the patients will respond. So learning is very, very important. Very important. I would say that placebo response is a learning phenomenon, at least in most conditions we have studied so far. The second mechanism is genetics. There are many genetic variants which respond pretty well to placebos. We have to be very careful in this field as well, because we are at the very beginning to understand the genetics of the placebo response. We know only something about some neuropsychiatric disorders. Just to show you very, very quickly, in some neuropsychiatric disorders like social anxiety, like depression, this is a known neuropsychiatric disorder, IBS, for example, there are some genotypes in red which respond pretty well to placebo treatment, and some other genotypes here in blue who do not respond at all. I mean, this is not surprising. Many neurotransmitters are involved in this psychological effect. So if there is a polymorphism, if there is a genetic variant of a neurotransmitter, it's not surprising that also the placebo response is affected by the polymorphism. And the third mechanism is personality. Personality is emerging as an important component of placebo and nocebo responsiveness. Unfortunately, again, we know very little about personality traits, but there are some personality traits. For example, unique hypnotic suggestibility. Some studies have found that there is a relationship, a correlation between hypnotizability and placebo responsiveness. And optimism or pessimism, this is not very surprising. Optimists respond pretty well to placebo, pessimists respond pretty well to nocebo. But we have to be very, very careful to consider these mechanisms. So I would say that learning for sure is very, very important. Genotypes, different genotypes are important in placebo responsiveness. And now, quite recently, some personality traits as well. So the last part of my talk, the merging model, clinical implications. There are many clinical implications, but I would like to draw your attention only on a single clinical implications. I feel it's quite important. In general, it's important. I think it's important within this context as well. This is the merging model. As I said, I started with this model. After all, drugs and placebos use the very same biochemical pathways. You see here different psychological factors, the psychosocial context, the ritual of the therapeutic act, placebos administration, positive verbal suggestions, modulate different molecules in the brain and activate different molecules in the brain which bind to the same receptors to which drugs within routine medical practice bind. So, for example, the psychological component can activate endogenous opioids, endogenous cannabinoids, endogenous dopamine, but an antiparkinson agent can activate the very same D2, D3 dopamine receptors, or a narcotic drug can activate the very same more pure receptors. Okay? So just imagine a situation in which you give a painkiller, you give a narcotic drug. If you give a narcotic drug, actually a narcotic drug binds to the more pure receptors and produces its effects, but expectation about receiving a narcotic drug activates the very same more pure receptors. So there is an interference between what you expect and what you get. What you expect, the psychological component, what you get, the pharmacological or pharmacodynamic component. So the last question I would like to answer is what happens? So after this model, what happens if we eliminate the psychological component? If we eliminate the expectation, which means the psychological component of drug administration, the question is the action, for example, of a painkiller, is the action of morphine the same without the ritual of its administration? So if we eliminate the psychosocial context, we eliminate the activation of all these molecules which are activated by psychological factors, and we can study the effect of drug. Is the action of a drug the same without the psychological component? How is it possible to eliminate the psychological component? You see here, this is a routine medical practice. Routine medical practice, this doctor is giving, I don't know, for example, a painkiller. This doctor is giving a painkiller to these patients. There is a very complex psychosocial context, some intravenous lines, some computers, and so forth. And the question is, what happens if we give the same drug, the same dose, with the same infusion rate? I mean, nothing changes. But we give the drug, same dose in this condition, what we call a hidden administration. Hidden administration of a drug, which means, I mean, the crucial point is that these patients do not know that any drug is being given, so they don't expect anything. They don't expect any clinical improvement, any therapeutic benefit, because they don't know that there is an ongoing therapy, an ongoing treatment. So just let me show you what happens for a painkiller. Well, actually, this is a very long story, but just to make a long story short, you see here, you will see the difference between an open injection what we call an open injection. Open injection means that, according to routine medical practice, a doctor is performing the injection, and the same drug, same dose, same infusion rate is performed by a computer. The crucial point here is that these patients don't know that a drug is being given, you know, that a treatment is being performed. You will see a reduction in pain here. For example, for buprenorphine, you see that an open injection of buprenorphine is more effective than a hidden injection. This is pain reduction. An open injection is more effective than a hidden injection, and this holds true for other painkillers as well, like tramadol, like ketorolac, and like metamizole. You see, for example, that metamizole or ketorolac, a hidden injection of metamizole is virtually ineffective. An open injection is significantly effective in reducing pain. This is quite interesting. You see that in our condition, a hidden injection is less effective than an open injection. This is quite interesting from a pharmacological and a psychological point of view, because you can separate the pharmacodynamic component from the psychological component. The pharmacodynamic component comes from the hidden administration, the hidden injection, because a hidden injection is free of any psychological contamination, of course. The rest is a psychological effect. You see, for example, for metamizole, there is a very small, if any, there is a very small pharmacodynamic effect. I would say that most of the reduction is a psychological effect. Probably it is very interesting to you to see how we run a clinical trial like this one. So I can conclude with this trial, which I think is quite interesting. You see here, for example, we try to answer this question: is metamizole, which is a painkiller, is metamizole at this dose, 300 milligrams, effective in this kind of post-operative pain, post-thymectomy pain? You know that according to classical clinical trial methodology, you have two groups of patients. One would receive metamizole, and the second group would receive a placebo. Then you compare a placebo with the metamizole. If metamizole is better than placebo, you say, yes, metamizole is effective. That's a classical approach. This approach is completely different. Both groups receive metamizole, which means both groups receive the active treatment. The first group receive an open injection of metamizole according to routine medical practice. The second group receive a hidden injection of metamizole, as you saw before. There is a full informed consent, because this is what we tell the patients. You will receive metamizole, but you don't know when the computer is going to deliver metamizole. It could be after 30 minutes, after 40 minutes, or 50 minutes. Just let me show you the progression of the time course of pain in a clinical trial like this one. You see that you will see here the time course of pain of an open or expected injection of metamizole and of hidden or unexpected injection of metamizole. The duration of the trial is 6-7 hours. Here, intensity of pain from 0 to 10. 0 means no pain, 10 means unbearable, very strong pain. And you see that we start from pain intensity of about 5. And here, the broken line represents the timing of metamizole administration. You see that right after metamizole administration, there is a reduction in pain. Here, there is nothing. You see that there is no effect. The crucial point is that at the end of the trial, we ask the computer, when did you deliver metamizole? Because now, here, the computer is delivering metamizole somewhere here, probably here, probably here, probably here, nobody knows. But you see that you can appreciate that there is a huge difference between the time course of pain here and here. Here there is an analgesic effect, here there is no analgesic effect. So at the end of the trial, we ask the computer, when did you deliver metamizole? This is the computer's answer, and you see that there is no effect, actually. There is no effect, which means that this is not the effect of metamizole, this is a psychological effect. If metamizole were really effective, we should see the same reduction here, but this is actually, if you like, you can call it a placebo effect, but I don't know whether or not it is correct to call it a placebo effect because we did not give any placebo. But it is quite straightforward because you can see that it is possible to identify a placebo response, the placebo component, without giving any placebo actually. You see? So this is a psychological effect. In this case, in this condition, of course, metamizole is not effective at all. You see that if you eliminate the patient's expectations, the patients do not know that any drug is being given or when it is given, you know, you see that, there is a huge difference between the two situations. If the drug were really effective, there should be no difference between this condition and this condition. For morphine, I don't have the slide here, but for morphine, morphine is really effective. It's a really effective drug. If you use morphine in place of metamizole, you would see a reduction here and a reduction here as well, because the drug is really effective. It doesn't matter whether or not the patient expects a therapeutic benefit, you know? This is my last slide, and this is the model which is emerging today. I had time to talk about pain. We know pretty much, you see, about pain. We know also something about Parkinson's disease. We know much less about the immune system, the hormonal system, something about some neuropsychiatric conditions like depression. Something about the cardiovascular system, like the beta adrenergic system, you know. And you see that this is a common phenomenon across different medical conditions. And the concept which is emerging today is that different psychological factors, which can be studied by using a placebo model, placebo administration, can use the very same biochemical pathways which are used by drugs in routine medical practice. Of course, the effect of drugs are much stronger. Of course, it would be better to say the other way around. I mean, that drugs use the very same biochemical pathways that are used by psychological factors, because during evolution, the psychological factors were evolved much earlier than drugs. Then human beings are very intelligent, so they discovered some molecules which can potentiate these mechanisms. And these mechanisms, these biochemical pathways are always there, are very important for social interaction and for, you know, for example, for tackling and facing different situations, different social situations. So the emerging concept is that different psychological factors, like cognitive factors, like motivation, like emotions, like the affective components, you know, of a patient, can modulate the action of drugs within routine medical practice. So last but not least, these are all my collaborators, both in Italy and in Switzerland, and you see that there is a very close interaction across different medical disciplines like neurophysiology, psychology, neurology, neurosurgery, neurosurgeon for the implantation of electrodes or recording from single neurons in awake Parkinson patient. Thank you very much to them. Thank you very much to you for listening.
Thank you very much. Is there many animal models now working on placebo?
Yes.
Placebo?
Yeah, there are many, not many. There are some animal models, and animal models. I mean, the placebo response in animals work like behavioral conditioning. It's hard to believe that a rat or a mouse can expect something, you know. So behavioral conditioning is very important. If you associate conditioned stimulus with an unconditioned stimulus, you can use a placebo to induce the very same response. The first paper which was published about the biology of a placebo was published in Science in 1962, and the title was "The Biology of the Placebo Effect in the Rats." And they found that scopolamine produces an impairment of motor performance. the experimenters found that an injection, repeated injection of scopolamine several days in a row, you know, then they replaced the scopolamine with the placebo, with saline solution. They found the very same motor impairment.
I get this experience. When I was in postdoc, my wife was a psychiatrist, saying she works, I don't remember the name, but you may know it's one of the most famous neuro working on squirrel monkeys and amphetamine, MDA. And I told her, you should, and he was looking at the behavior of the monkeys after an injection of MDA. And I told her, you should look what's going on with placebo. And it was exactly, she got exactly the same answer. And the guy never wanted to publish that because he had published 10 papers in Science without any control. Placebo, you get the same response exactly.
Yeah. Thanks for the comment.
Never published. It's one of the most famous of the people working on neurology of the answer to amphetamine.
Excuse me, is it just, I have a small question concerning the washout. You don't do washout after administering the placebo. Once you give the...
it depends. Yeah, washout is, pharmacological washout is very important. I mean, it depends on the condition. What condition are you referring to?
In the case of the growth hormone.
The
growth hormone.
The GH? You mean if we perform a washout? In that case, it was not necessary to perform a washout. There are healthy subjects. They don't take any drug. I mean, the administration of sumatriptan lasts more or less, and the action of sumatriptan, which means the pharmacokinetic of sumatriptan, lasts only a few hours. If you perform the very same experiment, instead of giving sumatriptan on day 1, day 2, day 3, you give sumatriptan on week 1, week 2, week 3, it's pretty much the same, which means that the washout is not important.
Sorry, I do have a test difference between people who are purging from the medics and people who are not, because if people have already took the treatment, maybe he can know what is the effect and can know that what he is going to have is different, is placebo. Have you ever?
Yes, if I understand your question correctly, I mean, if you give for the first time, yeah, of course it's different if you give after repeated effective treatment. Usually, is that your question? If
people have already had the treatment, you can know what is the effect of the treatment because you have already treated.
Yeah, of course.
If it is not the case, you cannot see the difference between placebo and treatment.
There are two mechanisms. The first mechanism is the conscious mechanism. As you say, if I receive morphine, I experience a reduction in pain. If I receive morphine for the second time, I experience a reduction in pain, and so forth. So what I experience is important. That's the cognitive component, the psychological component. But there is a component which is, I mean, these are placebo responses which are completely unconscious, like the cyclosporine A experiment, like the sumatriptan experiment. For example, just imagine a situation in routine medical practice, I mean, in daily life, in everyday life, in an aspirin pill. An aspirin pill, the active principle of aspirin is acetylsalicylic acid, you know, which is pretty effective, for example, in reducing your headache. But there is an aspirin pill has a shape, it is round, it has a color, it is white. After repeated association between shape, round, color, white, and headache reduction, there is an unconscious, completely unconscious association. So you can bet that after repeated association, every pill which is round and white can produce the very same effect. That's typical placebo response and unconscious. So you don't need to experience, to have a conscious experience. So I mean, there are both conscious and unconscious mechanisms. Conscious mechanism, you need to trust your doctor, if you like. You need to believe in your therapy. With the unconscious mechanism, you don't need to trust your doctor because the cognitive component is less important the Pavlovian or classical conditioning component.
But if you look at the question that I had that we discussed with, do you biologically, if you study the placebo response compared to the drug response, do you have any way to discriminate biologically what is, without doing a work test, to discriminate what is the pathway of placebo compared to the pathway of the drug?
Yes, you can do in some conditions. In some conditions, you can replace, for example, you can replace a real drug like morphine, like a narcotic drug, with a placebo, and you can use different techniques like brain imaging or like pharmacological approach.
Did you try to get, if you get biological tests that will trace the pathway of placebo specifically?
Yeah, that's what I showed today. I mean, in that case, you can map, you can track down the biological mechanism if you give only the placebo. What you can do...
it's not my question is that when you look at the patient where you give, effective drug and the most important response is linked to the placebo and not to the drug. Okay. Can you now, when you get this patient, do you analyze the blood and can you look on the blood sample? This is a placebo response, or this is not a placebo response, based on biological analysis?
No, you cannot do it this way. Probably you mean, I can say this is it's not a placebo response, this is a placebo responder, and this is a placebo non-responder. No, you cannot do that, actually, because we can anticipate.
This is a case that we need now. This is the case, because this is very complicated. So if you want to...
CCK does not change, it's not a biomarker. Probably what you mean, if you can use these biological these compounds as biomarkers. No, we cannot use. Because, for example, for CCK, we studied other labs all over the world, studied CCK, not detecting CCK in a blood sample, but by using agonist and antagonist, which is quite different. I mean, if you look at, if you want to look at a CCK concentration in blood, you cannot detect any change, actually. For endorphins, for endogenous opioids as well, the pharmacological approach is with agonist and antagonist. Yeah. We don't know why, because there is, for example, a beta endorphins, can increase in the body for different reasons. If you are under stress, for example, there will be an increase. So they are not specific, it's not really a specific biomarker for a placebo response.
So far we don't get one?
Absolutely, absolutely. You cannot predict in advance who is a good responder, who is not. We cannot say that there are some biomarkers like CCK or like beta endorphins or enkephalins, as a biomarker for a placebo response. Absolutely not.
Yeah, go ahead. I just wanted to know something like in homeopathic medicine, do you believe that there is more placebo response than the actual response?
Homeopathy is only placebo response. That's my opinion, but don't trust me because I work on the placebo. But my opinion is that homeopathy is only psychological effect, only a placebo response.
Because in India, I'm from India, so in India, even my father don't take allopathic medicine. So whatever he finds, he cures.
I know. I can say that there is a huge difference from a psychological, from a social point of view. There is a huge difference between a conventional doctor and a CAM doctor. The conventional doctor spends more or less the average. There was quite an interesting study, was published several years ago. A conventional doctor spends for a consultation an average between 8 and 10 minutes. A CAM doctor, an alternative doctor, spends between 55 and 60 minutes. There is a huge difference. So probably the psychological component is very important in CAM medicine, in alternative and complementary medicine.
But there's probably, we work here, you know, as I told you, there's a problem that we have that is pushing now is the people who claim that pain, fatigue, and so on was the post-Lyme disease. This is very, very big. And we get a psychiatrist working specifically on this thing, and she's doing hypnosis, which is placebo as well. But what is different, what is interesting is what she said is that in some case where hypnosis is not working, she's giving pills placebo, and this is working. So it's not exactly superposed. So there is people susceptible to hypnosis, which are, and some who are not, but are still susceptible to another form of placebo.
We don't know exactly what the difference between hypnosis and placebo is. There are many differences from biological point of view. For example, as far as we know today, hypnotic analgesia is not mediated by endogenous opioids, for example. There are a few studies, but the few studies we know, there is no mediation by endogenous opioids. And some people claim that hypnosis, after all, the difference is that with placebo, when you give a placebo, you tell the patient just once your pain is going to decrease. With hypnosis, you repeat many times. Your pain is going to decrease, your pain is going to decrease, your pain is going to decrease. But to be honest, we don't know exactly what the difference is between hypnosis and placebo administration.
Just clearing what about the homeopathy that was discussed. I had the same question, and I went to one of the homeopathic doctors in India who was very well known, and I asked him whether his medicine actually works, because in my father's case it didn't work. So I asked him, and he said the first medication that we give is actually the effective one. After that, whatever we give for 3 months or 2 months that follow is actually placebo. That's what he told me. And he said that the first medication that we give is the effective one, but we give the placebos because patients usually don't believe that just one pill or one dose will be effective. So to keep them in this head, they keep giving this medication. That was
Thanks for that. Thanks for the comment.
You said that placebo effect won't work in infectious disease. But infectious disease, but the immune system is involved, so don't you think it could be?
It could be. There is no. We don't know. The most honest answer is we don't know. We don't know. I would be really surprised if you give. If you tell the patients, I'm going to kill your bacteria or your viruses, and actually you give a glass of fresh water,
or you're naive.
I think that nothing happens.
No, I think you're naive.
You think so?
No, we have several infectious diseases where we compare placebo versus antibiotics or placebo versus antiviral, and placebo do as well.
We have to be very, very careful. I understand, but we have to be very, very careful because in all infectious disease studies there is no real control, and the control is the no treatment. Because for example, a placebo response could be not so much a psychological component, a psychological effect, but could be spontaneous remission. It could be selection bias in a clinical trial. It could be what we call a regression to the mean, which is a statistical phenomenon in clinical trial. So I'm not sure.
Some of the symptoms, when you were talking about nocebo effect, one of the things in nocebo effect that is really surprising is the nocebo effect in vaccination, for example. There is, of course, allergy, there is skin, but there is fever as well.
Okay.
So that means that you may real fever. So that means that some of the components that you have are on the placebo or nocebo effect, and probably susceptible to placebo effect, including fever, pain, and rash. So this is not so simple. So, but well, usually people say, as pastor, of course, you know that infectious disease is simple as a bug in a human being. That's not the case. That's very, very complicated. Any field is complicated. It's just a question of knowledge. It is complicated. And there is really placebo versus nothing. You're right. So the main problem, this is what we were thinking about, you know, having a clinic for treating people with post-TB exposure. We need to get placebo versus nothing versus components. Because if you don't compare that versus nothing, of course, you did not demonstrate that it's a placebo effect. I agree with you.
Fever would be very interesting, I mean, to be studied for sure. Fever, because you know, aspirin is both an antipyretic and analgesic effect. So aspirin and placebo aspirin can act on cyclooxygenase, so I would not be surprised that, there are no studies unfortunately on fever, but I would not be surprised that, I don't know, a sort of conditioning or pharmacological preconditioning with aspirin